Wednesday of the month for at least 4 months. So we are scheduled right now for September 16th and October 21 as well, focusing on how to support healthcare providers to improve health equity and decrease disparities, as Liana noted. The next two are actually going to be focused on building trust in the relationship as well. So with that, I'm going to, again, keep us going and turn to our panelists, who thanks again so much for joining us today, and thanks all participants as well. So Carl.
Yes, good morning. It's a pleasure to be here. I'm Carl Tony. I'm a physician assistant. I've worked clinically in internal medicine and geriatrics. And over the past few years, I've been working in both public health and healthcare planning, particularly around trying to support immigrant and refugee communities here in Maine, initially through the University of New England with our Center for Transcultural Health, and then over the last few years with the City of Portland and the Minority Health Program and the Center for Grieving Children. I will limit my remarks to say that from the perspective that what I've been trying to do in each one of these settings is to help the communities that are at risk through the immigrant and refugee communities for a variety of healthcare issues, help them become more comfortable with the healthcare system here in Maine and the Western healthcare system in general, and to try to also help providers become more comfortable with a new set of patient populations that bring a variety of not only different healthcare issues, but more importantly, a different set of cultural norms and expectations. And certainly with the onset of the coronavirus, those issues on both sides of that equation, the community and the providers, have only been heightened in terms of trying to provide appropriate care and for communities to be able to understand exactly what the situations are, what the risks are, and what they should do. So hopefully over this hour, we'll be able to answer some questions for folks about how best to work with the communities and particularly understand their situation from their cultural norms. So I'll stop there.
Lisa, you're muted.
Sorry about that. Thank you so much, Carl. Just saying, I think it's apparent from Carl's comments and the other panelists that they really bring a real wealth of experience working with people from diverse communities. So with that, Dee?
Good morning. My name is Dee Sabatis. I am a citizen of the Passamaquoddy tribe at Indian Township. I currently serve as the health director for the health facility for our tribal nation. I historically have spent the last 18 years doing national health policy on behalf of American Indians, Alaska Natives across the country. So Leanna, you want to put up the slide really quick? I just wanted to give a brief overview. Many forget that there are tribal nations within the state. So there are currently 5 tribal nations within Maine. Over 573 tribal nations across the country. Many of the tribal nations have direct treaty and trust obligations with the federal government. So the documents that you're seeing to the left that are kind of with the beige color are actually snapshots of the treaty and trust obligations that are the treaties that the Passamaquoddy people have with 1, the federal government, and 2, the Commonwealth of Massachusetts. So those treaties afford tribal nations a different relationship with the federal government. We maintain a political relationship beyond just those treaty and trust obligations also provided an obligation for healthcare. One that is grounded in those treaties, but also grounded in the U.S. Constitution. However, the Indian healthcare delivery system is a chronically underfunded system. Of course, underfunding leads to increase in health disparities. So we each year get approximately 42% of the budget we actually need to provide healthcare to our citizens. So add that onto the social and economic impacts that are affecting a majority of the communities that we're talking about today, it only exacerbates the struggles that we have, especially in a pandemic time. We've been fortunate we haven't had the increases in the amount of COVID within our communities, but there are precautions that we'll talk about later that we've done to make sure that that doesn't happen. So I think that's a little brief history of kind of the healthcare delivery system within the tribal system within Maine. A little bit different from what you're doing. We deal with our citizens are seeing our providers, so we're able to monitor that care. But it's still, even though we're monitoring the care, some of those underlying factors are impacting the health of our people. Historical and generational trauma really really add to what the disparities are showing within our communities. So finding ways around that is important. We've been able to look at the cultural aspects, tying culture and tradition into the work that we're doing, which shows impact to the healthcare that our people have. So I'll stop there and then let the others go into their introductions, and then we can get into more of the questions.
Great, thank you, Dee. Next is Lisa Tappert.
Hi, everyone. Thank you for having me on this panel. I'm really delighted to be here, and I just want to give a shout out to all of you healthcare providers who are living through possibly the most difficult time you've ever lived through. I know in our practice, we try to take a few minutes to breathe deeply every morning, and I hope the same that all of you have the same opportunity. My background is that I have a public health degree and that I worked for 25 years in global health in Africa and Asia. Now I live in Maine, and for the past 7 years, I've been in charge of the Maine Mobile Health Program, which on the flyer it says is part of Maine Med, but actually it isn't. We're independent, we're a federally qualified health center, and we are designated to serve Maine's farm workers. And so that is seasonal and migrant farm workers. About 78% of our patients are more comfortable in a language other than English, and that's primarily Spanish or Haitian Creole. That doesn't mean that everybody else is a native English speaker. It just means that we have a diversity of languages being spoken by our patients and a diversity of cultures. I want to just say that since March, in collaboration with DHHS and Maine CDC, we've been planning for incoming farm workers to Maine and made an ambitious plan for COVID-19. I don't think we realized how ambitious it was until we got started. But in collaboration with Penobscot Community Healthcare and other partners, we were able to complete all of that testing. And that resulted in some of the quote unquote outbreaks that you heard about in blueberry workers. But we are very proud of this work. We feel that we were able to identify 31 cases of COVID-19 before they became sicker or spread to their small groups in the camps and into the local community. I think one of the lessons learned from all of this, though, is the incredible toll that this testing had on our patients and how complex it is to be a contact of somebody who is COVID positive, especially if you're coming in from out of state and you're not familiar with the Maine health system. So in our next round of testing, we will be paying special attention to that, doing more education before the testing happens about what could happen if people test positive. And COVID testing is just a part of what we do. We typically provide primary and preventive care to the workers that come in through mobile health services and in collaboration with a wide range of hospital, health center, and other health providers across the state.
Great, thank you so much, Lisa. And last is Nicoletta Toma.
Hi, everybody. It's a pleasure to be here. So my name is Nicolata Toma. I'm an internal medicine trained physician, and I recently completed the preventive medicine fellowship at Maine Medical Center. I have worked with patients from racial and ethnic minority groups throughout my career, both as a primary care provider and through my fellowship training more recently. One of the opportunities that I had last year was actually to have a rotation with the Maine Mobile Health Program, LISAs, and providing care to the migrant farm workers. And I had a chance to really witness firsthand how the program help decrease this very significant healthcare disparities that this patient population is experiencing by providing access to care as well as language and cultural brokering. More recently, I've also been involved in the Ask a Doc sessions that the Maine Accent Immigrant Network have organizing this summer. And this is 1 hour weekly sessions, members of different communities where they can ask questions, mostly COVID related, but other healthcare issues as well, with the CHOS providing the translation. So that has been very illuminating in realizing the questions on the minds of the
Great, thank you, Nicolata, and all of our panelists. And I'll also say, I think the program you just referenced, Nicolata, you've been very gracious about sharing some of the learnings that have come from that. So we'll talk at the end about maybe ways to share some of the tools and best practices. So I'm going to just throw out some questions to all 4 of our panelists, and maybe just do a raised hand if you'd like to jump in or when you'd like to jump in so we can signal the others. But we're just going to sort of go around and invite folks, our 4 panelists, to jump in, and then as Liana noted, we'll have at least 15 minutes at the end for Q&A. You can put your questions in the chat anytime, or when we get to that, you could unmute yourself by mousing over the bottom left-hand side of your screen. So to start, we know that a lot of people from diverse communities face particular challenges, particularly around social health needs, sometimes referred to as social determinants of health, but their own social factors that might get in the way of care. In your practice, have you seen that? How have you seen that? And how do you see it impacting individuals, particularly from racially and ethnically diverse populations? Be shy, our panelists. So just raise a hand if you'd like to go first or when you'd like to go next, and then unmute and jump in.
So I guess I'll start.
Great.
I spoke a little bit about the drivers of healthcare within our communities, and those social determinants have had major impact in access to care. So although we have this treaty obligation for healthcare, the system doesn't allow for a comprehensive care. So we're also having to refer out to other outside. So we can do everything they can to get them there, but really the social determinants are really impacting them, because if you have to make a decision on whether to put food on your table or go to a health appointment, you're going to put food on your table. And that's what we're seeing, because our poverty rates for the tribal communities within Maine are around 33% as compared to the US population of 15.5%. So add that on top of the increase in health disparities, that can the overall health of our people. What we're seeing also is the average age of death. The average age of death is drastically low for tribal communities. It's 58 years old as compared to 72. So in our tribal council area, if you're an elder, your picture is on the wall. Our elder, we have to reduce our elder age to 60. So if you meet 60, you've already beaten that statistic. I can tell you right now, we've got about 48 pictures on that wall. So most of our citizens aren't living long enough. And it's the impact to the overall health because of these drivers that's, making them, die earlier than the rest of the population. So we're trying to change that within our health system. We do a comprehensive care that really goes away from or incorporates traditional medicine into Western approaches. That has been beneficial for our communities. It really tailors the healthcare to their needs. And so we're hoping that by doing that, it increases those rates and we're not seeing those health disparities within our communities.
Yeah, thank you, Lisa. One of the things that we've seen is the struggle for the communities to try to maintain their cultural identities and cultural norms once they arrive here and end up trying to move in two directions at once, if you will, to maintain who they were, but also try to successfully integrate into the Maine and Western society. So a lot of the issues that we come up with are based around both that kind of push-pull type of situation and the confusion among families about who they are and how they function in this society. Another piece I would add that again has been an ongoing issue and I think is going to become even more of an issue because of Corona has been the issue with the children. The work that I've done with the Center for Grieving Children, we work with immigrant and refugee children around the traumas that they have faced in trying to get here from the countries and circumstances that they left, and then trying to become integrated into this system here. And then that set of issues is further complicated by what we've come to appreciate as kind of the intergenerational trauma between the younger children who are becoming westernized and their adult parents and family members who may not be becoming westernized or at least at the same rate. And so this whole issue of how to communicate and how to understand the systems that they find themselves in. Again, these kinds of situations are only hearing as we try to deal with Corona and people understanding how to live their lives, often in a communal way, but be safe, how to go to work in situations that put them at risk and be safe, and then how to access the healthcare needs that they have in a way that maintains their cultural identity. So everything from food and lodging and the need for faith support and so forth are all things that are complicating the situation for the communities, at least here in Southern Maine.
Great, thank you. Lisa Tapper, I think you were looking to go.
So I really agree with everything that's been said. I think for health providers, it's important to recognize that by the time one of our patients gets to your office, they have overcome numerous barriers, and those have been the supports to overcome those include, in our practice, a team of community health workers who are bilingual, who provide interpretation, transport, help with prescriptions, and that's all essential. But I would say that, there are structural barriers to health equity that we are all aware of, like poverty and racism. And I would really, really encourage anybody who hasn't undertaken anti-racism training within their organizations to look into that. There are some excellent trainers. And I, having worked in this organization and across marginalized populations for my whole career, learn something new every day about what I'm doing to contribute to the structures that are in place. But I also want to just say that in Maine, where it's a small state, we have small populations. I've seen individual commitments by leaders of organizations who are not willing to say, I can't do this because, and instead say, we are going to do everything we can to help these patients. We are going to go the extra mile. We're going to try to fill in the gaps. I know it's 5 o'clock, but we're going to spend a couple extra hours to really make things happen. And I think, I just want to say, like, Penobscot Community Healthcare is one of those organizations where they never stop really trying to bring equity. And I've been really impressed by that. Mono and Mono is another organization that has just really know that everybody's saying we can't do this, but we can. So I've seen incredible work done on individual levels, and I know it's a hard time, but the patients that we're seeing need help more now than ever. They're essential workers. They're coming into Maine from Florida, from New Jersey. They don't have the choice to stay home. And so, you know, the people on this call are really able to contribute to health equity, obviously. Thanks.
Great, thank you. And Nicoletta, do you have anything you want to add to what's said, or we can keep going in terms of particular strategies to help address some of these issues in COVID?
No, I agree with everything that has been said, and I think, you know, in just a couple of points in the primary care setting, you see so much of those social determinants of health and how they affect particularly the immigrant population, but not only. And things like, you know, language barrier, definitely socioeconomic status, income, ability to afford medication, you know, transportation challenges, ability to get to appointments, housing conditions, you know, multi-generational housing where you cannot decrease the spread of infection, or, you know, poor living conditions like mold and, you know, worsening respiratory conditions, or homelessness. And you know, there's so many things that we don't that impact people. I think we don't. We can talk about this a little bit later. I think providers don't always know all of those factors. I also think that what Lisa mentioned earlier about the implicit bias and looking at, I think that's also an important point.
Great. So just pivoting a bit, many of you have referenced how these social health needs impact people in this time of the COVID pandemic. So maybe just a little bit more about strategies that you've seen effective, or maybe even more about how these social health needs particularly impact during this time. I think folks would really love to hear what you're doing. So Lisa Tappert, you mentioned PCHC and your organization and Mano Mano really needing to sort of flex and bend and expand services, or maybe service times, other specific strategies that you've taken to try to meet those needs. And we'll mix it up this time. How about we go back to you, Nicoletta, to start.
Sure. So, you know, I think the particularly related to COVID. I think some of the how this create barriers. A lot of the when you in the immigrant population, one of the biggest challenges is truly getting the information out and getting the education out. I think that is a big gap, and I think one of the things to bridge that gap is the community healthcare workers to kind of transmit that information, help providers communicate that information into the community. You know, I think the social norms of the racism and structural racism is a really important factor. I think you know, the language barrier is also very important in being able to for the immigrant population to be able to access the same amount of information that an English-speaking population is able to access. I think I'm sorry, Lisa, can you please repeat the question?
Are there specific steps that you're taking to help address some of those social health needs for disparate populations, the diverse populations related to COVID specifically?
Sure. So I think the, so for example, the ask the doc session. So what we've been trying to do is to specifically answer those questions from the community. And it's really, I think it was a very eye-opening to see the type of questions that the community, the immigrant communities had. And, you know, they were truly the same questions that you really see in the entire community. Is that the only thing is that you know, the language barrier and the difficulties accessing care can limit how they can get that information. But I'll just give you a couple of examples that that really strong. So you know, people were asking about you know, people were asking about things like, does vinegar help disinfect compared to the diluted bleach, and adolescents get infection and people get reinfected. And then the questions were very astute. Some of them were, you know, what can be done about the fact that if you don't speak English, it can be very difficult to access your test result, to get the information. And then there was also one question that I remember thinking that's extremely astute, and was, why isn't there a, you know, a centralized database for the test results where all the providers can access? You know, I think it's a good way to disseminate some of the information. The other things that the preventive medicine fellows have been doing, they've been working with DHHS and the Catholic Charities in writing some educational materials to be disseminated, to be made available to patients while they are at testing sites. So those information on how to decrease the spread of infection, what to do when you get tested, how to isolate and quarantine yourself, and what resources are available if you need to quarantine yourself. And those are currently being translated in different languages. I think 18. And the idea is to make those available at ER or Swab and Go, or the hospitals, the testing sites. The other thing that's also an example of the things with the preventive medicine fellowship that we've been doing, have been working with the homeless community around Portland, doing site visits and advising on infection prevention techniques and workflows for testing and quarantining. And also in the homeless population, helping providing access to telehealth, so iPads made available so that those patients, those residents can access healthcare, which has been really difficult to do otherwise. So I think those are some of the examples I have.
Great, that's a lot. Super, terrific. Others?
Well, I do want to say one more thing about specific strategies for testing. I think, as I know this is the case in Southern Maine, but for our patients, the test can open up a whole world of hurt in terms of people needing to stay out of their work setting. And one of the things we did prior to testing, because we did group testing at employer sites, is worked really closely with employers to make sure that sick leave was going to be available to workers that had to quarantine. It wasn't a perfect system, but we sort of talked to employers saying, you know, the other people in your industry are providing this, will you? And there are some federal supports for that. But I think that bringing in behavioral health providers to help people cope with the COVID diagnosis and to help support them during their quarantine is really important, for them to have access to that service so that they can ask questions and get their questions answered. A lot of times, I think people are in quarantine and, you know, the very first thing they learn is, oh my God, I have to go into quarantine. And then the questions come on the third or fourth day when they don't quite know, like, am I getting out of quarantine at 14 days? Will I have to be retested? What happens if I have symptoms? What about the rest of my family? And all of that kind of stuff turned out to be sort of a tidal wave for for us that needed constant attention. And I think, something that Carl said that I think is really important is when people are in quarantine, there are systems in place to provide food. And I've heard it said that, if people are complaining about the food, then they're doing pretty well. But I actually take issue with that and think that in these communities that we're talking about, culturally appropriate food is essential. We have people coming from outside the country, from other cultures, and them receiving food during their quarantine that is not only unfamiliar to them, but not necessarily, unfamiliar to them, can be really difficult and contribute to people leaving quarantine and needing to go out and find the food that they can eat. So I think that can't be underemphasized.
Great, okay. Dee, you're unmuted. Do you want to jump in?
Sure. I think some of the strategies that we've had a little bit more flexibility as a sovereign nation within a sovereign to be able to control a little bit of the impact that COVID has had on our community. So some of the strategies that we've utilized are just that we've done some security protocols for entering our tribal communities. So only residents are allowed to enter unless you have a permit. And then we're testing those that are entering our communities within 12 hours of them arriving. So we've also, to really be able to reduce the impact of COVID in our communities, we've been able to do some drive-through testing for COVID. We've also done some mobile testing. So we are going to them, those who have the transportation barriers, we're going to them, we're testing them. And we've been fortunate we've been able to do that. So we utilize a bunch of different testing mechanisms that have reduced our COVID rates. But also communication strategies, as Nicoletta mentioned, those have been very important in our education to our community, making them aware of the resources that we can provide them in the event that they do test positive for COVID. I think that has eased fears a little bit, but has also helped us in maintaining a very, very low COVID rate within our communities, which isn't necessarily the norm for tribal communities across the country. With the high chronic disease rates within our communities, we were terrified. We were terrified that once impacted into our communities, that it was going to wipe out our elders, our knowledge keepers, our storytellers. And I think that's what helped us in keeping it away, because they wanted to protect those people and our elders. So they were taking extra precautions and safety when it came to COVID.
Great. And Carl, additional thoughts from you in terms of?
Thank you, Lisa. The two things that came to mind that I wanted to add was we've been working with providers to try to, again, help them emphasize the social history part of their workups on their patients, so that, again, they better understand who these people are and what their lives are like the 23 hours and 45 minutes they're not in the examining room dealing with this issue. And as part of that, to try to encourage and make available interpreters so that you can deal with language in a more effective way, certainly the community health workers for outreach, but also cultural brokers to help interpret from an understanding perspective for the providers what the community individual and collective perspectives are, but also help the communities understand what the medical perspective is. And the last thing I would say that I wanted to add that we're doing is reaching out within communities to try to identify and establish community partnerships around what we're calling trusted voices within the communities. And these can be faith leaders, but other individuals within various communities of whom the community looks at and for good, trusted information. And so that's why we call them trusted voices, to help get the word out to the communities, to help address issues that are coming from the communities, and to particularly help around the social service support issues, which seems to be one of the places we're really falling down in providing a network that protects the communities as they're going through either the testing, the quarantine, the treatment, or the convalescence. So again, I would say community partners, trusted voices, and the use of cultural brokers along with interpreters.
Great, thank you. So we are, I think, probably at a good point for taking questions from folks, unless any of our panelists want to jump in. Although I might ask, I saw Sharon, Sharon, if you want to unmute, just to that point that Carl just made, and I think a couple other folks about social supports from DHHS. It just seems like a timely moment to mention that. Sharon, can you, there's too many screens for me to scroll and see where you are right now, but
I'm here.
There we go. Beautiful. Thank you.
Unfortunately, I have my husband's name, or fortunately, I have my husband's name on my screen. I think that Nicoletta has some slides and basic information that she's providing with the handouts for this, but DHHS has funded a first round of CAP organizations, community action programs, to at least be sure to provide social supports to anybody with that's in isolation or quarantine, that if they can't work, if they need a place to stay through Maine housing, if they need food delivered, culturally appropriate food. So that at least got a quick round of funds to 10 CAP agencies plus Wabanaki Public Health and the Catholic Charities, just to keep moving. And then those agencies are subcontracting to organizations across the state. And then there is a phase 2 funding that will be coming that Liana may want to talk about, that is offering funds to organizations that are working on the ground. But this includes, masks, housing, food, diapers, thermometers, depending on what people need. We've been working with Lisa most recently to be sure that the various agencies that need to do, that can provide support to people in isolation and quarantine are available. We are available to anybody who's been asked to be in isolation and quarantine. Inbox, which I'll put in the chat here, that a provider, community leader, a patient themselves can reach out if they're COVID affected, and we can make sure and see what people are eligible for and help tie that together for them.
Terrific, thank you. And I did a terrible job of introducing you. Sharon. Sharon is a physician with a long history of working both nationally and internationally on issues of outbreaks, including with US CDC, and we're fortunate to have her here in the state of Maine now, and Maine DHHS has contracted with her to help us provide social supports for individuals during the time of this pandemic.
I'm very excited about the next phase. I think that we're going to get to see a lot of organizations step up and take over care of their communities, and also get a chance to really show how care can be done in different ways. So starting this week, organizations are putting together their proposals to do the work that they think is really necessary. And I think that we're going to see some very interesting things with collaborations with schools, healthcare organizations, community groups, that's being done by local communities. And I think there'll be a lot of lessons learned.
And then Lisa, you also commented about Inza Watara from Catholic Charities. Inza is going to be a panelist on one of our future webinars, but I see he's on today. Inza, do you want to unmute and speak to the videos that Lisa Tappert just noted in the chat?
Hi, yes, this is Inza Watara, State Refugee Health Coordinator. I'm really happy to be here, and this conversation is very, very helpful. Yes, I am working with Maureen from Maine Medical Partners. We put the video together that what testing is and what to expect after testing, and if you need any support for isolation and quarantine, what to do. And my translation is complete. today. I got to know that all the translation have been completed. So now we are looking for what Carl has said. I am personally looking for trusted voice in the community to put voice over those slides, and then we are going to also share it to places where these community access services, healthcare services. So I can say that in the next couple of weeks, this material will be out to help bridge all those gaps that people are mentioning around testing, isolations, and also accessing to social services in order to kind of properly follow the COVID safety guidelines in these minority communities. So.
Great, thank you. Nicoletta, were you going to jump in?
Yeah, I just wanted to add one thing and on the social support services. So the one change that providers might not be, some providers might not be available, might not be aware of, sorry, is that currently they are able to refer patients that are suspect or probable of COVID to those social support services if they identify them as in need of isolation or quarantine support. Which I think is very relevant because with the delay in the testing results, which can be over 1 week, if you can only offer those support services at that time, you're wasting time and you miss that prevention opportunity. So Sharon shared those slides that she prepared. They can be made available, and there's information about the type of questions that providers need to provide to make the referral in the email where the referral needs to go.
Super, thank you. And then I'm just going to note that Dr. Sharon McDonald again put in the chat the email to make a referral to Maine DHHS for social supports. So you can see it right there, dhhs.covid social support at maine.gov. And that is truly for anyone, any patient, individual that you see who you suspect has COVID and you identify a social health need while they are in quarantine or isolation. Am I saying that correctly, Sharon? Great, okay. So again, we're happy to take questions. You can either, I don't think I'm missing any here. Several comments, thank you. But if anyone has questions for our panelists or for the group, feel free to put them in the chat or to unmute. Noted, they check the emails every day, 7A to 7P, forward them to the social service agencies with a goal of having a response within 4 hours. That's terrific. And she's putting her personal email at maine.gov in there as well, sharon.mcdonald. So thank you for that, Sharon. You also referenced Aunt Bertha. Do you want to make a comment about that, Sharon? I'm not sure everyone knows what that is.
Well, I'm just learning about it, but basically it's a social support program that links with the EPIC medical records program through Maine Medical Center and Maine Health. And in that, physician or anybody that works with the system can go in and find out, based on geography or types of programs needed, relevant social supports or community-based organization, mutual aid that's available to them. And we got a tour of it just the other day to sort of understand how providers of any sort might be able to go in and look for things that are relevant to information that would help patients, whether it's educational or direct community support.
Great, thank you. To clarify, I think right now that's a tool for folks in the Maine health system that have access to EPIC. I don't think it's a wider statewide accessibility right now, although there are discussions about how to make tools like that available, but just to be clear on that.
Lisa, this is Cassie Grantham. You can access, as a patient or community member, you can access the list of available supports and community organizations, just as a physician or medical provider can. It is a web link. It's actually a web-based service. It's just that we are able to connect it. Ellen Friedman is just one of our program managers, just chatted in the link, and it's available in different languages. So it is available.
Super. Thank you, Cassie, for correcting me on that. I didn't realize that. So the difference is just that Maine Health are getting at it through the EMR and maybe the communication loop, but others can access the information, you're saying.
That's correct. Yep.
Super. Great. Okay. Thank you. And there's the link. Thank you very much. Tina Holt is, she's got it in there for the Portland area, specifically 04101, but you could do it for any zip. So question from Angela Leclerc. I'm a critical care provider interested in more education and or resources for critical care and end of life care as it pertains to the beliefs of our minority and diverse populations. Anybody want to take that one? That's maybe tough. Most of our providers here are working in outpatient settings, but any thoughts on that?
Well, this is Carl. I would say that there are a host of community organizations, immigrant and refugee organizations, coalition that you can reach out to that can help you identify folks who can come in and work with you around those kinds of issues, either from an educational perspective and or from helping to create the most appropriate environment to deal with that. So everything from, certainly from Catholic Charities and Portland Public Health and Maine Immigrant and the folks up in Lewiston. So there are a number of community organizations that if you reach out to them with that kind of request, they can put you in contact with folks who would be able to help you with that.
Great, thank you.
I would suggest that the Maine, that MERC, the Maine Immigrant Rights Coalition, can connect you to multiple, they're sort of in some way a clearinghouse for community-based organizations from that represent different countries and different origins. And so it's, I'm not sure if I can, it's the, I'll just put the name and
Folks can find the link, I'm sure.
yeah.
There we go.
But I think when we've dealt with end of life with our patients, you know, it's so, the resources so depend on where people are from, and there are so many people from so many different places that our community health workers have been really integral to trying to access different resources for those kinds of situations.
Great, okay. Got the link again to Aunt Bertha. Thank you for that, Ellen Friedman. And then from Dr. Kenji Saito, are there good resources around unconscious bias or maybe implicit bias? We sometimes call it training within healthcare in Maine. Who wants to take that one? Is anyone from Hanley Center on? I know they've done a lot of work on that.
I see Kathy.
Kathy Vizina, formerly with the Hanley Center. Kathy Vizina, do you want to unmute and chime in on that?
Thank you, and it's good to hear from you, Kenji. There are a number of different resources. The Hanley Center does provide training, and I do some work with them doing that kind of work. There's also cross-cultural community services, a small nonprofit that is made up of actually 3 principals, Decca Delac, Abdir Ali, and Regina Phillips, and they're doing a good bit of that kind of training around as well. I know that there are a lot of other folks that are doing more work in those areas that I haven't worked with, but those are two areas that are available for people at this point.
The other resources I would mention are, and Lisa Tappert, thank you, I think also put in a couple of the ones I was going to mention, which is Racial Equity Institute, as well as Race Forward, do a lot of racial justice work and unconscious bias, but also just racial equity work. Nicola Chin, who is locally works here in the Lewiston area, and her nonprofit Uplift Community also does a lot of organizational and institutional work. And then MindBridge, which is, thank you, Sharon, has put in the link. So there's a lot of great resources, both locally and nationally doing this work. Certainly some of our leaders within healthcare like Hanley have really honed in on some of this work as well. And so happy to have offline conversations if folks have additional questions about that.
And Liana, can you type your email in the chat as well so everybody has that? We'll also be sure to copy all the resources and comments here. Liana, I think it's fair to say we're still sort of figuring out within Maine DHHS web pages where to post all this info, but that's an active project right now, and we will be in touch with folks about being able to get both the tools that have been referenced here and many of the organizations and links today. Other questions from folks? Either, again, you can chat or unmute.
I would love to ask one, for those of us, we set up social services to support contact tracing, and that we started that in June. We've been able to serve about 250 referrals for a total of about over 500 people in Maine. But we really need to get the word out so that people do know that services are available. And that will include both getting directly to the public, but also providers. So anyone, please feel free to reach out, especially as we add more providers in the Black and Brown communities. I'm hopeful that this will be appealing to people to get care from folks that they know in languages that they understand, that are familiar.
Great, thank you. A question from Martha Morrison. Hello, Martha. What are we doing? What could we do to better ensure attention on social determinants of health within the medical environment on a routine basis, not just in a crisis? I suspect there are several folks to that. I will say I think that there's been a growing attention to the issues of social health needs and how we identify and help connect people to resources around those within several healthcare organizations, both nationally and in the state over the last several years. Several of the provided groups, I think, are really putting more systems in place to routinely screen for social health needs and then to help connect people through one of the various social health platforms, such as Aunt Bertha that was referenced here. There's also an ongoing statewide conversation about is there interest in combined efforts around a social health needs platform in the state so that social health organizations don't have to necessarily populate 18 of those. So if folks are interested in that, feel free to let me know. We've got the next conversation actually I think coming up tomorrow about that. But I think you're absolutely right. It has to be fit into our thinking about approaches with patients. Additionally, we're seeing lots of references to community health workers, which I think is another key strategy to be able to identify and work with folks around those social health needs. Lisa Tappert, you were just chatting in your work through Maine Mobile and work with community health workers. Did you want to speak to that?
Just to give people the information that if they encounter folks that are doing farm work and we haven't referred those patients, feel free to reach out to us and we can get them connected to services and often pay for some, if not all, of their care. And that's anybody who's doing any kind of seasonal or migrant labor. And I just also want to say that the question, how can we better ensure attention to social determinants of health? I think it's the anti-racism training is the first step to turning this into a more structural approach. I think without that, you're kind of putting Band-Aids on the solution, no offense, Band-Aids. But that is, to me, the most important first step for an organization to take, is to make a real commitment to anti-racism and to recognize white privilege and the racism that we all hold within ourselves and address it.
I just would love if our panelists could also reflect in our last 2 minutes on, as the pandemic has phases in some ways, right? And needs may shift and change. What do you want providers to think about in terms of service to minority communities as the pandemic is shifting? What should be at the forefront of our minds? What should we be planning for proactively?
I'll go first really quick. So I think the role of the community-based organization and community healthcare workers there should be, I think, both more funding, more resources for those, and also more education to providers, more awareness that those services are available. I think that's a very important part of the problem. I think Lisa and other people mentioned also provider education on implicit bias, so that you don't, assume necessarily that patient is not compliant, when in reality it's those social determinants of health that you don't always probe into, like housing conditions, living conditions, income, food insecurity, and so forth. And I think this pandemic really shines the importance on those questions and figuring out those high-risk individuals or providers.
Great, thank you. And I would love to hear more, but we're at the end of the hour, so I'm so sorry. But this really is, one of our planned many times to continue this conversation. So thank you all, really appreciate it. Liana, anything else you want to add in closing? Okay, so remember I noted at the beginning that we're planning these webinars as a monthly, at least we plan an initial 4-month series on the 3rd Wednesday of the month. So the next would be Wednesday, September 16th, and we're keeping the 7:30 a.m. time. So thank you all for getting up early and joining us. Again, a huge thank you to our 4 panelists, Carl, Dee, Lisa, and Nicoletta. And thanks all of you for joining us and for your interest in this topic and your efforts to serve people across our wide range of communities in Maine. So thank you all.